Well, my name's Joey Fougerousse. Let's see. So I'm actually native of Baton Rouge. I kind of grew up here, went to Parkview Baptist for high school, went to LSU, it's down the street for undergrad, LSU New Orleans for med school. Figured I might as well try somewhere other outside of Louisiana, so I went up to Birmingham, Alabama, to UAB for my medical urology training. Just finished up this June and fortunate to come back home. Fortunately, my parents are here, my wife's parents are here. We have a 3-year-old son. He's a lot happier playing with his grandparents than he was up there. So we're glad to be back. I'll get to the end. So I just joined. I'm with the group Louisiana Urology. So our office is at Bluebonnet and Perkins. I'm currently taking new patients. If you have any issues, I'd be happy to help you. And thank you to Pennington for having me give this talk today. So I'm just going to cover some pretty, I call probably the most common things as urologists we deal with the fourth being kidney stones. But I think these are important for, I can give you all just a brief overview of, what to look for in these topics. So we'll start off with, what is PSA? So it stands for prostate-specific antigen. So this is a protein made by the prostate. Its only purpose is to help, kind of mature semen, make sure they're mobile. It has to do with our fertility when we're younger. Other than that, it's pretty useless when you get old. But what we've kind of learned it can do, since it's a protein that circulates in the bloodstream, we found it's an easy way to screen for prostate cancer. So it can be elevated in prostate cancer, as well as BPH, but also a few other things, and I'll kind of elaborate on that later. It's not the perfect test. So like I said, why do we care about PSA? Because it can be a screening tool for prostate cancer. If you don't know, prostate cancer is the second most common male cancer, only secondary to skin cancer, and it's the second most common cause of cancer death, only secondary to lung cancer. 1 in 7 men will be diagnosed with prostate cancer at some point in their life, and there's usually about 175,000 plus new diagnoses every year. But off that, the data shows about 30,000 men per year die due to prostate cancer. But fortunately, that's on the rare side. Only 1 out of 41 people diagnosed with prostate cancer will actually die from the disease. So that means it's very treatable, even curable, and stances. And one consideration is prostate cancer, large in part, about 90 to 85% of prostate cancers are pretty slow growing, pretty indolent. It's not by and large not a very aggressive form of cancer. Honestly, if I had to pick a cancer, God forbid, it'd probably be prostate cancer, because a lot of times it's slow growing and we have a lot of different treatment modalities for it. But the issue is there's a subset of prostate cancer that's about 10 to 15% of them are pretty aggressive, they rapidly spread, metastasize outside the prostate, and those are the ones that cause issue. And one of the issues is it's hard for us to tell just based off PSA, like who's got what. It's hard to tell which ones are going to be aggressive, which ones are going to be the friendly kind. So kind of moving on, a lot of y'all may have already had a PSA drawn, maybe familiar with it. A lot of primary care doctors, everyone's a little bit different, and we'll kind of, once again, elaborate on that in a second. But just some basic normal numbers. So PSA, the expected baseline range should increase with age. So it's someone under 50, normal levels, under 2.5. As they get 50 to 70, expected to be less than 4. And then once you're greater than 70, a little more tolerance could be up to 6.5, and that's considered normal. So it's when, So the question is okay, when do we need to look at this further? And I would say, in my mind, PSA is something that kind of just raises the flag. It's it's not, those with a super elevated PSA, not all of them have prostate cancer, but they could. So that's let's look into this. Let's see, what's really going on here. Let's find an explanation for this increased PSA. So one indication for traditionally be just a biopsy, and I'll elaborate on nowadays. Likely we'll get an MRI before we go straight to biopsy. Once get more detail on that as the presentation develops. But if you're PSA, so if you're a 50-year-old and you're seeing me and you've got 2 documented PSAs in the 20s, that's an issue. That needs to be looked into. Or if, say, you're now 60, we've been checking your PSA since you're 50, and it was low. It was like 1, 1.5, 2, and then suddenly it's 3, 5, 7. You kind of get that upward trajectory. That's going to raise a flag to me. It's like, what's going on here? Let's look into this. And lastly, an abnormal digital rectal exam. So that's everyone's favorite. If we feel any lumps or bumps, that's, again, another indication of why we need to look into this further. And just to kind of give you all a reason, a lot of things in life, if I know why someone's doing something, I feel more comfortable about it. So why do we have to do a DRE? Because the prostate is right here. It sits right in front of the rectum. So it's an easy way we can palpate the prostate. So feeling lumps and nodules. And typically if we feel any nodules or asymmetry, just something that's not smooth, that in my mind, that's usually the more aggressive forms of cancer, or it's a later stage of cancer. Now, it doesn't mean a lot of time. So if you have a normal exam, it doesn't rule out cancer. But if you have something abnormal to where something has grown to form a palpable nodule, that's an issue. So that's something that would require further investigation. So kind of then some background on using PSA as a screening tool for cancer. In mid 2015, 2016, there's been some controversy around it. So there's kind of two governing bodies that give national recommendations as to what to do for screening. So when it comes to a screening tool, we want it to be accessible, cheap, and actually find what its goal to find. It's useless if it it only tells you 50% of the time if you actually have this like that. So what ended up happening is that USPTF, so it stands for United States Preventative Task Force, is like the governing body of all fields of medicine. They're the ones that tell you, okay, you need to get your colon checked starting at this age. They kind of give those national recommendations to all of the United States. And that's kind of a big deal because it kind of has to do with the way money's allocated to certain things, and because ultimately, it can kind of play a role in what they think is important as a screening tool. And then, so that it all kind of stems back to when we started using PSA as a screening tool. So it was 1993 is when it's and then we thought we hit the gold mine. It's oh man, we finally had this simple blood test. It correlates with people getting prostate cancer. If it's elevated, it's a sure, we thought it was more of a sure thing. So there was this huge diagnosis of people with prostate cancer in the mid to late 90s, early 2000s. In the data, the graph just goes through the roof. There's all these new diagnoses of cancer. We thought, we're finding it. But over time, what we found is, people with clinically insignificant prostate cancer, we've learned more about the course of the disease, that, hey, it is kind of slow growing, it's not real aggressive. Those people that, were dying of other diseases instead of prostate cancer, we're still getting treatment for prostate cancer, and, you don't want the treatment to be worse than the disease, right? People will get infection, so there was some data kind of showing that aspect of it. Well, the urologist decides that doesn't tell the whole story. Like I said, there's still that 10 to 15 subset of patients that got really aggressive disease, and we can't really predict it. So we can't just stop screening, because if we miss those guys, then we're going to go back to what we were seeing in the 70s and 80s, people showing up with metastatic disease in your clinic, and by that point, it's kind of too late to do anything. So we found some middle ground, a lot of litigation, 2018, because they had put us at D, which means discouraged use of the service. They said, hey, stop screening. Like that, as a urologist, we're not okay with that. We finally got, we got it bumped up to a C, meaning, you may provide this service depending on individual circumstances. So it became more of this kind of shared decision-making kind of blanket. Let's individualize it to use the patient with all your, all your health considerations, your life expectancy, quality of life, etc., to see what's right for you. Essentially, this is kind of reiterating what I said before. We don't want the treatment to be worse than the disease. Go for that. And then, ultimately, it's been if you live long enough, you're probably going to form some form of prostate cancer at some degree. It's more about depending, who do we need to catch it early to prevent it before it becomes a problem. So once again, now we can kind of get to, okay, we had this bickering back and forth, so who do we think needs to be screened for prostate cancer? Once again, in the past, 2016 said no, now we're aligned together. So now the recommendation is all men 55 to 69 should at least get a PSA and a DRE at least every year, every other year, just to keep tabs on it. And then we also include those starting at 40 to 55 if you have a family risk of prostate cancer, or if you're an African American, you have genetically higher risk of forming prostate cancer. Those are the people that need to start earlier, because they're more likely to have a more aggressive form of cancer earlier in their life. That if you catch earlier, you can keep it from progressing to something that's could be a lot worse. And then once again, I keep harping on, it's for the most part extremely slow growing. So the USPTF says, hey, you should stop at the age screening at 70. Because even if you're diagnosed with cancer right now, the chances of being your cause of death is pretty low. Like most people, men are going to die of heart attack, stroke, other more common things than prostate cancer. The AUA, so that's the American Board of Urology, essentially says, hey, we don't fully agree with that. Once again, let's make it shared decision making. Because like you could have a 70-year-old run a marathon, super healthy, is different from the patient that's got a lot of other comorbidities, has had 5 heart attacks. Like those are not the same patient. You can't have like this blanket term for everybody. That's why I would say evaluate it on a one-to-one basis. And then, essentially, we agree, screen over 70. Obviously, the reason not to screen from the USPTF is like you don't want to do overtreatment, no harm. So once again, I think if any urologist should evaluate the patient as a whole to see what's right for them. And just of note, and then one thing that kind of got us pushed back into PSA screening is, sure enough, after 2016, for those next 2 or 3 years, we started to see much more advanced disease showing up in clinic that probably would have otherwise, had we screened, had been caught earlier. And then so kind of getting back to, PSA is not a perfect screening tool. So what are the things that can cause an artificially inflated PSA? One, if you just have a bigger prostate, it's going to make more protein, so you're going to have a higher PSA. Infection. If you ever got urinary tract infections, it loosens up the tissue in the prostate. More of it gets in your bloodstream. Or inflammation. It could be something as simple as you're a cyclist, you ride your lawnmower, you ride horses, riding your Harley. Anything that puts pressure on kind of your buttocks, the prostate area, is going to bump it up temporarily. And then in the past, sometimes we'd have these patients like, okay, he's 55, his PSA is like 4.2, it bumped up to 5 and down to 4, and you kind of have those people that kind of fall in the intermediate. They're not super high, they're not super low. We've done a biopsy before, because it used to be before MRI, which I'll elaborate on. It used to be elevated PSA, you get a biopsy. So that's when we put a transrectal ultrasound probe in your rectum. They take standard 12 cores. They kind of divide it up into a pattern. Kind of sample it, take 12 cores and look at it under the microscope, see if it's cancer or not. Well, if that came back negative, but then you still have this elevated PSA, you're like, well, we did a biopsy once, and then, let's do another biopsy. People were getting a lot of biopsies for negative. We didn't have any other tools to kind of say, okay, what else is going on? Well, fortunately, about in the past, 5-10 years, we started using MRIs of the pelvis and the prostate as been a significant tool to help us target prostate cancer. Because imagine before, you have a dartboard, right? You throw 12 darts. That's kind of what the biopsy was. You're just getting these 12 little samples. You're not sampling the whole thing. You're just getting, who knows where you're getting. There could be cancer in between those 2 darts. It was not precise. So fortunately with MRI, we now have the imaging, and we can see if there's lesions, and we can categorize those lesions into essentially low, medium, and high risk, and we can target those under biopsy, and that's kind of been the game changer. And what kind of drove that? There's this big study looking at it. So 500 men, 250, we went the standard pathway, just standard 12-core biopsy, and then the other 50% ended up getting an MRI. And obviously, some people have an MRI and don't have any lesions, then we have to go back to just this 12-core. But most days, if your PSA is high enough, it's going to detect that lesion, and we can target it. We usually do 3 or 4 biopsies of that lesion, and it showed a 50% higher detection of clinically significant prostate cancer. And I think that's the key here, is clinically significant. So this is now the tool to help us divide, okay, because like I said, to help find those higher risk patients that do have cancer that's a little bit more aggressive. So this has kind of been one of the big revelations in prostate cancer management in the past 10 years. And then come on, two other caveats. Once again, I can't keep on coming back, harping on it. It's all shared decision making. So not every recommendation applies to everybody. Because you could have, say you had this 55-year-old came in with a PSA of 6, got the MRI, did have the small lesion, we biopsied it, and it came back as like very low risk prostate cancer. We call Gleason 6. That's the patient. He could live 20 years before that'd be a problem. So why do aggressive therapy, whether that's surgery or radiation, is going to change his quality of life when he's otherwise happy and healthy 55-year-old. So what we do in that situation is called watchful waiting, where we check PSAs about every 6 months, potentially get repeat MRIs. If we see evidence of progression of disease, that's when we pull the trigger. Because once again, we have time to wait it out. It may have just been a super early diagnosis before it's had time to potentially convert to a more aggressive form. On the flip side, you could have this 80-year-old man who was diagnosed with high-risk prostate cancer, and even the high risk, you still have several years before it even spreads outside the prostate. And say, why do other therapies that's going to worsen his quality of life? Or say, he may have other comorbidities where he may not live, expected to live 4 or 5 years after that. So why do something if it's not going to show true benefit? So there's essentially prostate cancer therapy is getting very individualized for the patient, so we can essentially maximize your quality of life. And other tools we have in conjunction with the MRI is either different ways we analyze the PSA, or now there's all these genetic markers they can look at in your urine. They done some pretty high-powered studies that have shown that certain markers are associated with more aggressive diseases. Once again, we just need better tools to identify those 10 to 15% who have aggressive cancer. Those are the ones we want to catch. So in summary, the decision ultimately comes down to the patient, their PCP or the urologist, to do what's best for them at their current station in life. There's multiple ways to screen for PSA these days. It's not one applies to all. We have our guidelines, but once again, you have to use some clinical judgment and talk with your patient to see what's best for them. And the last thing I want to harp on, I wouldn't ever get scared if, say, your PSA has been rock solid low your whole life. If you get a call from your internist oh, it bumped up to 7. Like I said, there's a lot of other things that can cause it. We don't get excited about one elevated value. The first, if someone sees me in clinic and that's all they have, reassure them hey, let's recheck it now. Hopefully it's been 6 to 8 weeks since that first draw, because you may have had a temporary elevation. If it comes back down, we're saying not going to worry about it. We'll just keep an eye on it. So I want to reassure y'all, we don't make any harsh actions after just one lab value, because it's not perfect. Okay. Well, I'll kind of take a pause there. Does anyone have any questions about PSA screening or screening for prostate cancer? All right.
How do you tell the difference between fast growing and slow growing?
You mean the aggressiveness of the prostate cancer? So that's what I'm saying. All of these kind of these tools, the risk. So what we do now, these can help us. Some of these tools can help us identify if you have genetic predisposition for aggressive prostate cancer, or a lot of the times what it comes down to the way the cancer looks like underneath the microscope. It's kind of in the weeds here. I can briefly, there's something called a Gleason score. It's what we use to grade the abnormalities of the prostate tissue. So they're actually in the works of changing this up, because it's trying to explain this to patients. You're like, why? This makes no sense. But essentially it's Gleason 3, 4, and 5, with 5 being the most atypical, meaning the most likely to be aggressive, with 3 being the most favorable. 1 and 2 are essentially normal tissue. 3 is like the first one we call cancer. 4 is somewhere in between, and then 5 is aggressive. So if you get, essentially the higher the number, the more likely it is to be aggressive. But that's what the pathologist looks like. It looks under the microscope.
And all that is on a blood test.
So all these are on a blood test. So the Gleason score only comes after you get a biopsy. That's where they actually take the tissue itself, look at it under the microscope and different stains to see what we're dealing with. Okay. Yes, sir.
So, diet, obviously diet shouldn't have anything to do with whether or not you're going to get prostate cancer.
The only thing we've known is Agent Orange for people, I guess, from the Vietnam War. That has been known to have some degree of correlation with a lot of cancer formation, but specifically prostate. Okay. All right. But yeah, diet in general doesn't affect the prostate in whether cancer or BPH, unfortunately. If it did, that'd be a lot easier. So the next thing I like to talk about is erectile dysfunction. So I know it's something, maybe a lot of men don't like to talk about with other men, but we're in a room with all men. I'm a urologist. It's my, just my duty to show you what we can offer you, what the available treatments, and so forth. So obviously it affects about 30 million men, and 50% of men, obviously it gets a little bit worse as you get older, 40 to 70, and it can be treated. But a lot of times it's secondary to another chronic disease. The most common being cardiovascular disease. And we've got some data showing now that ED, if you're otherwise healthy, the onset of erectile dysfunction can be like a precursor to more like heart disease or stuff like that, because it's all about blood flow. If once the penis starts getting poor blood flow, that means whatever changes happen in the arteries are also affecting the heart. So there's a big correlation between those two, as well as hypertension and diabetes. So diabetes, once again, affects the nerves. You get like peripheral neuropathy. People get tingly hands and feet. Same thing happens to the nerves going to the penis. They get affected as well as hypertension. Once again, the heart and the penis have a lot in common, and they both get affected by the same thing. And even a lot of the drugs to treat the hypertension, beta blockers is a big thing, thiazides, a lot of other antihypertensives, there's a ton on the market now, can all play a role. And the biggest thing is lifestyle, stress, alcohol abuse, smoking, even obesity can play a role. And then outside of kind of those things, specifically other urological issues, so people that do end up having prostate cancer, a lot of the therapies that treat the prostate also, so the nerve fibers that go to the penis, they form a blanket around the prostate. So any treatment you do for the prostate affects those nerves, can lead to erectile dysfunction. And kind of getting on to, so dealing with it, obviously it's going to negatively impact your life. So people have, depending on what's going on in your life, maybe losing confidence in the bedroom can cause obviously relationship problems. It's more than just a physiological thing. I don't think I need to elaborate on that. I think everyone kind of has an idea how it can affect you mentally. But just kind of the basics of how like an erection works. So it's all about blood flow. Once you're getting stimulated, you're getting aroused. Your brain, since the hormones and the nerve signals and the blood flow, your cardiac, your heart starts pumping a little bit more to send arterial blood flow to the penis. And this is like if you just take a slice right through the penis, you have got 3 big chambers. So these top 2, these are what we call your corporal bodies or your erectile bodies. These are what actually get engorged with blood. They actually fill and give you an erection. That's what makes it firm and gain length. And this little round tube here, so that's your urethra. So that's your P tube. And so what happens, you get a bunch of arterial blood flows. That's the high pressure blood flow. And then your body also has mechanisms to cut off the outflow. So you got blood going in, not much blood going out. That's what makes things erect. And that's kind of the physiology behind it. So all of our therapies, ultimately try to replicate that. And these are kind of like the 5 mainstays of treatment modalities. It's kind of a stepwise, the least invasive to the most invasive. So we start off with medications. These are like your Viagra, Cialis. Then there's penile injections. There's Trimix, Bimix. I'm not going to get in the weeds about all the different ones. Vacuum erection devices. There's even some insertable medications. It's kind of like a suppository for your urethra. I'll get to that in detail. And then kind of the end of the game, end of the line is penile implants. Just a warning, there's a lot of I call it like fake news when it comes to ED treatment. This is the statement from the American Urological Association, our big board. If you get offered any of these, they're just trying to get money from you, turn around and go away. Unless they're offered at like an academic institution, unless you're going to like New Orleans or to a place that are doing studies and they tell you, hey, we're doing a study to see if this actually works. Like the shockwave therapy, the platelet-rich plasma therapy, the stem cells, that's all experimental. And they'll charge us $6,000 for nothing. So stay away from that. And once again, we'll start talking about the medication. So oral drug therapy, everyone's heard of it. Like I said, Viagra, Cialis, Levitra, Stendra. Fortunately, Viagra and Cialis are generic now. So any of the Afil, Sildenafil, Tadalafil, these all work by promoting better blood flow to the penis. Just trying to assist your body's natural ability to do that. They're not perfect. They don't provide an immediate erection. A lot of times you have to take it 30 minutes to an hour beforehand, and always want to take it on an empty stomach. A lot of times it's not super conducive. Say you have you want to go out to a nice meal. Well, that big old steak is going to sit in your stomach, and that medicine is going to get diluted. You're not going to have nearly as good effects to it. And then it got some side effects. It's all variable. Some of them have different side effect profiles. And usually, you can try one. If it doesn't work, they are different enough that another one may work. So usually, someone's like, okay, I've tried 100 milligrams of Viagra, doc, and it works a little bit. It's not working great. Can I try something else? And then that's when I'll try Cialis next. Stendra is still a little bit pricey. It's still brand name. That's the newest one on the market. Once that one goes generic, it'll probably be a good option. Even the side effect profiles can be different. The biggest complaints I hear, headaches, and with the headaches comes like the facial blushing, like it gets more blood flow to your brain, and that pressure is what you feel as a headache. It can also cause nasal congestion. It's all variable. Everyone reacts a little bit different. And then penile injection therapy. So the biggest hurdle to get patients over is like, doc, you're telling me to put a needle in my penis, right? Like most people don't love that, right? They're like, what's going on there? But those that, so it's kind of it's the next best option. I think if the medicines aren't working, but I really don't want surgery, I'm willing to try this. It actually works pretty good. The medications, because it's the only downside is you have to have you have to have a syringe with the medicine with you wherever you're at. And then how would you play it off in the bedroom? You go to the bathroom. You can be discreet about it. It takes some strategy, but the actual results of getting erection are much better than oral medications. It's quicker onset, and this is the one you're more likely to get priapism. I know that Viagra, they love putting that in the commercials, right? It's like if you get an erection longer than 4 hours, call your doctor. It works great. But like this is the one that actually does that. So this is but for real, if you do get one in 4 hours, it's you can celebrate, get some high fives, but like you need to call me because it can be a problem. Next, it's an option. It's an old school thing. It works for some people. There's a learning curve to it. The device can be a little bit. Once again, this is the one I think would be the most inconvenient if you're trying to be spontaneous in the moment. But it is an option. The big thing it pulls venous blood flow, which is colder. So you're not. It's going to feel. You're going to notice that sometimes you get inconsistent ejaculation. Like I said, there's a learning curve to it. How to use it right. I'll mention it, but unless someone comes asking for it, I'm kind of indifferent about it. Insertable drugs, once again, it's just another option. I think this is also like kind of the middle ground between the injections and oral pills. So this is something that actually goes in the tip of your penis, like where you pee out of. It's a suppository. It's a medicine that gets absorbed by the lining of your urethra. So it acts directly on the penis. I'll say it works pretty good, usually within 10 minutes. And usually you get erection for 30 to 60 minutes, depending on everyone's biology. It can cause some burning when you pee, because obviously you're putting something in the tip of your penis. It's one of those things that's just another option. Last, so this is the end of the line. So this is like person, I've tried everything. I've got this new, or me and my wife, or whatever situation to where they want to be sexually active again. This is the end of the line. So this is a surgical therapy. I perform these surgeries, but it's called inflatable penile prosthesis, or we call it a 3-piece IPP. Verbiage, you may see it anywhere. But you actually there's a little video coming next, but you get these 2 implants that go in the erectile bodies, so that will fill up with fluid that's stored in this reservoir here, and then there's a little pump that goes down your scrotum. So it's kind of like on demand. And for people, I think kind of get the best of both worlds because you can be flaccid, normal, you're not going to be walking around all day with a half chub or something. And then but it also, it does the best at replicating our natural anatomy. Let's see if this will show. Hold on. There we go. And I'll kind of point it out. I think it's one of those things like you got to see how it works to understand it. So they got two implants that go on each side of the body. You have a reservoir that goes in the pelvis, and there's some tubing that goes down to your scrotum. So this is the flaccid state. The fluid's in the reservoir. This is like, not using it. And then there's a little pump that goes like in between your testicles, within your scrotum. So everything's underneath the skin, and you literally pump it up. It's like it's called, and it can work. So, and it's going to stay as rigid as long as you need it to. All your nerves, you pee just fine. Sensation is not altered. And then when you're done, there's a little button you press. You deflate your penis, and it goes back in the body.
Wow.
But this has been out since like the 70s. It's not new technology. So that there's two big companies on the market that make it. And here's the most important part. Patient satisfaction is 98% based on their studies, right? But then Partner satisfaction, 96%. There you go.
But your girlfriend could accidentally deflate it.
You know, that's that is a possibility. That is a possibility. Once again, I'm just giving you all the options available. Not everything's right for everybody. And the last is, we don't use this a whole lot. So it's called a malleable. It's almost like the Gumby device. It's kind of like semi-rigid is what it's called. These are for people, they don't have good dexterity. Maybe they can operate the pump, but still want something there. Once again, we don't use this a whole lot. But it's another option. And then just brief caveat, these are surgeries, and no surgeries without its own risks. The biggest which would be infection. The device itself lasts about 10 years. There's some risk of erosion, meaning it's part of the device eroding through the skin. All those are very rare, but it's my due diligence to give you nothing without risk in life. And then we'll move on to BPH. But does anyone have any questions in regard to erectile dysfunction? All right, let's go ahead and move on. So this is something else that's probably going to affect everybody. So starting around age 60, so the prostate's like your ears and your nose. It's going to keep growing the older you get. You just get bigger and bigger. So most will be affected by the time they're 80. And just some kind of size assumption. So like when you're young, it should be about the size of a walnut. And then as you get older, it starts getting bigger and bigger and bigger. And that becomes an issue because I like to make the analogy, it's kind of like a donut. When you're young, you got a nice donut hole, urine can pass through, no problem. Because the bladder sits on top of the prostate, it's a muscle, has to squeeze the urine through the prostate. So if it's a big hole, no issue, free flowing, it's just plumbing. But as you get older, the hole gets smaller and smaller and smaller, and it starts constricting up on itself. And that's when you start having a lot of issues. And essentially any therapy, medication, or surgery we do is to make that hole bigger. And just to make sure we don't get confused, so BPH is different from prostate cancer. Obviously, this is just benign enlargement. This is just growth of normal tissue that starts to become symptomatic due to its size, not due to cancer. And I'll just what does that do? So when your bladder's fighting so hard to get through the prostate, these are the common symptoms you get. You got a full tank frequency, meaning, man, I'm going every hour, and then I go to the bathroom. And then 10 minutes later, I got to go right back to the bathroom again. It's probably not emptying everything out. Or you're getting up at night 3 or 4 times a night. Man, you're not getting any sleep. Or sometimes you get the sudden urge, like, oh man, I got to go pee right now. You kind of run to the bathroom. Or that intermittent stream, you start, stop, dribbling, even pain. All these symptoms are due to overgrowth of the prostate. And it's obvious how it can affect your quality of life, right? These are people, man, I can't drive 4 hours to go see my family. I got to stop at the bathroom every 30 minutes or something like that. Or not going to activities where bathrooms nearby. Disrupting your sleep. You're getting up every 3 to 4 hours. I mean, this is something a lot of people have gone through. And so what is the workup for this, just in general? Like every doctor gets you good history, make sure, look at the whole patient, not just the prostate. And then there's something called the International Prostate Symptom Score. So this is a standardized questionnaire that allows a urologist to see what exact symptoms are you dealing with that can help tailor therapies to what you're going through. I think everyone should fill one of those out. If you come in with those kind of symptoms, I'm going to hand you the sheet of paper. I know it sounds silly, but it's a metric that we can track your progress over time. So if we start another therapy, we want to see that number go down and so forth. It's a good tool to track progress. There's certain indications to where it's, we're going to have to do surgery. So that would be, sometimes you can get so much overgrowth that you end up in retention. If you're having recurrent infections, if you're having bladder stones, kidney damage, sometimes the urine's backing up so much it backs up into your kidneys. That can, if you do that for a long time, that can cause prolonged kidney failure. Or sometimes when the prostate gets so big, it's a pretty vascular gland. It's got a lot of blood supply. Some of those vessels can get thin and start popping. You have blood in your urine. I mean, those are the more extreme end of the line, but it happens. But then, on the other extreme, it's like sometimes we don't have to do anything about it. The one for those that have very mild symptoms, like I get up once at night, or sometimes I go to the bathroom, I have to go right again. But The first question you hear from me is like, well, is it bothersome enough that you're going to take a medicine every day for it? Some people are like, no, and like, you know what, that's fine. As long as you're not having those infections, kidney damage, as long as that's fine, that's fine. Like this is really just a quality of life, metric here. So common treatments, the most common of which is Flomax. We're called tamsulosin. A lot of primary care doctors are giving those to men. You don't even have to see a urologist to get that, but that's usually the first line therapy. So that's what this medicine does. It relaxes the muscle fibers within the prostate to kind of open up that channel on its own. Another medicine type is called the 5-alpha reductase inhibitors, or finasteride, Proscar, anything that ends in uride. So that over time, that will actually shrink the growth of the prostate, but it takes a lot of time. It takes time for the prostate to kind of shrink. Usually you don't see benefit till 3 or 6 months down the line. It's not something that's going to work overnight. It's more of it's a medication that's been a while. I'm not a huge fan of it because of the side effect profile. In the same manner that it uses to shrink the prostate, it has to do with your testosterone levels, that it can cause lowered libido, and even something called gynecomastia, to where men start forming breast tissue because instead of going to testosterone, it goes to estrogen. Not a huge fan of it when there's a lot better therapies out there today. And then, believe it or not, we found that Cialis, which is traditionally used for erectile dysfunction, lower doses every day has been shown to help with opening up the prostate, relaxing, and also gives you benefit if you do have some mild degree of erectile dysfunction. It's like a 2-for-1. And once again, it's shown benefit combination of any of the three. And last, so if you've been on medical therapy, you say, Doc, it's still not working. I'm still getting up 4 times a night, having a lot of issues. Then we talk about the surgical therapies. The most traditional of which is called the TURP. It stands for transurethral resection of the prostate. Also the Roto-Rooter. I don't know if you ever heard that term. So essentially we go in and resect the central part of the donut hole and open it up, make it a donut hole again. Because essentially the tissue kind of grows inward. We resect all the tissue that's blocking the urethral channel. It's still a good procedure. Once again, but there's some other options on the market now. One of the more less invasive ones is called the UroLift. Essentially, it puts these clips that go into the center wall of the prostate and clip it out to the outer wall of the prostate. So it's kind of like putting up like a retention wall, holding the walls of the prostate open. That one's not perfect, but what it does do is a lot of these other medications and treatments will result in what's called retrograde ejaculation. So when you go to ejaculate, instead of your sperm coming out your penis, it actually goes backwards up into the bladder. It doesn't cause any harm. The only issue is if you're trying to have kids, obviously it's not going to work. So, but the UroLift actually preserves that. It's a consideration for maybe those in the younger population that may want to have children. Another option is Resume. It's actually used steam ablation. It's super high tip steam that kills all the tissue surrounding the urethra to open up the channel. There's laser therapies, a variety of which again ablate the tissue. And then lastly, if you have a very large prostate, talking like grapefruit size, sometimes these aren't going to work, and you have to physically remove that obstructing prostate through like a surgery. All of them have their pros and cons. It's a little beyond the scope of this kind of brief talk, but there's just options available. Like if you get to that point, urologist should give you all the options. I think that's it. But once again, Joseph Fougerousse is my name. I'm at the Louisiana Urology Clinic, right at Bluebonnet and Perkins. We're like the surgical specialty center. There's Brock's on the first floor. Which I'd be happy to take care of any of y'all. If you have any questions, just let me know.
Thank you.
You're welcome.
Well,